We will get started in a few minutes. We'll just give folks a few more minutes to join and then we'll get started. Mr. Musafri, do you want to just check and make sure you're able to share your screen with the slides?
No.
Yes, it'll work. Excellent. So good morning, good evening. We'll just maybe give it another minute or two before we get started. You may want to go into presenter mode and then for the slides. There we go. Yeah, perfect. Okay. I think one more minute and then we'll get started. Just give folks a little bit more time to start signing in. Okay, great. Beautiful tea garden, picture of tea gardens there, or
Yeah, terraced farms.
terraced farms, yeah. All right, I think we can get started. So welcome everyone. Good morning and good evening. My name is Purba Chatterjee, and I'm the Associate Director for Global Health Equity in the Department of OBGYN Bixby Center, as well as the Institute for Global Health Sciences. And it is my great pleasure today to introduce Mr. Tumusime Musafiri, a public health researcher and project manager at Partners in Health, based at the Butaro Cancer Center of Excellence in Rwanda. Mr. Musafiri holds a BSc in Biomedical Laboratory Sciences and an MPH in Epidemiology and Disease Control, and has over 8 years of experience leading research and implementation projects with both governmental as well as non-governmental organizations, including PIH, ICAP Columbia at Columbia University, then the African CDC, as well as the University of Global Health Equity in Rwanda. And in his current role as the Patient-Centered Cancer Care Research Program Manager, Mr. Musafiri's work focuses on developing and evaluating interventions to improve patient-centered cancer care in Rwanda. And the title of today's talk is Improving Patient-Centered Communication in Rwanda Through Cultural Adaptation and Empowerment. And then following the talk, we'll have a brief discussion facilitated by Dr. Rebecca DeBoer, and she's the Associate Professor in the Division of Hematology and Oncology here at UCSF. Thank you for doing the discussion for us. And this lecture series is actually part of UCSF's Institute for Global Health Sciences Global Partner Spotlight Series, which is designed to catalyze scientific connections across the world, bringing together diverse voices and perspectives to inform the future of global health. And this is the sixth talk in this series. And with that, I would like to invite you all to warmly welcome Mr. Musafiri, and we look forward to your talk. Thank you. Over to you.
Thank you very much, everyone. Can you hear me?
Yes, we can hear you.
Okay, thank you so much. I'm called Tumusime Musafiri, as she mentioned, Pibra. I work for Partners in the Health, and I'm glad today to be here presenting our work that we are doing in collaboration between PIH and UCSF. So my talk of today will be based on the following key points: global oncology and cancer care in Rwanda, as well as our research to adapt the communication intervention in Rwanda, based on the communication skills training that we are providing to the clinician as our intervention, and patient-reported quality measures, as well as the Q&A. So she has highlighted my background. I worked as my foundation's biomedical laboratory scientist, worked with Ministry of Health, as well as other NGOs, including Veterinary Health. You can see the pictures from here. That's where I was in the laboratory, like providing some explanation around the sample processing into the laboratory. That was 2016. And the following picture, it shows me presenting after entering into the research space, where I was sharing my research within Rwandan research health policy, the Rwandan context. So later on, I joined also I did the transition from lab tech, lab scientist to the research role, where I first became Mercury Research Project Manager. I was working in the project global research, if I can say, which was aiming to leverage community health workers to combat health misinformation. The project was being conducted in Rwanda, Haiti, and Malawi. Later on, if I can say in 2 years almost, I joined oncology research as a patient-centered cancer care project manager, leading a collaborative project between PIH and UCSF, with the collaboration that has been there so long, in a couple of around 10 years, I mean 11 years, in the collaboration between PIH and the UCSF. So I was also privileged to meet Dr. Becky, as she is the PI under this project. So I wanted to dive in, but I wanted also to highlight the contribution and our founding member, our co-founder as Dr. Profama. He highlighted the partnership in his way, where he said that with rare exceptions, all of your most important achievements on this planet will come from working with others or in the world partnership. So he knew that the word partnership, it's the path towards where scientists and the global leaders, they could meet and discuss like the challenging issues globally. And this is the opportunity that I've been given, also thanking the IGHS team to give me this opportunity to share what we are doing in that context of partnership. So the global cancer burden, cancer has been highlighted as persisting challenges in the global context, where it has been reported that between 28 and 2030, cancer death is expected to increase by more than 80% in LMIC countries. That includes Rwanda, where I'm located right now, projecting like 10 to 11 million cancer diagnoses each year by 2030 in LMIC countries. Despite that, the issue that we have seen, low and middle income countries face disproportionate unavailability of cancer services, where it has been reported that in 2017, 26%, only 26% of LMIC countries reported having pathology services. That is the issue that we should also be discussing here. Less than 30% of raw LMIC countries reported availability of treatment services as an issue. So here, I'm reporting this slide as the disparities that shows mortality gaps between developed countries and developing countries, less developed countries or developing countries. So it shows that in the 2030, most of cancer deaths and death regarding breast cancer and cervical cancer, we have increased number of breast cancer from LMIC countries by 2030, as well as cervical cancer by 2030. You can see that the differences between more developed countries as well as the less developed countries, and what really that is where that we need to provide maximum resources into our low and middle income countries. Then what do we need to do as path to overcome this issue? Like if I can talk about the IGHS here, we have really the framework which we can use while mitigating the ways of overcoming the issue of cancer in the future. We have different categories where we can use prevention. We do have an anti-tobacco campaign that should be put in place, HPV vaccination, in the part of screening, pap smear, mammogram, colonoscopy as one of the methods that we can use. Diagnosis also, we can go through the basic pathology molecular diagnostic, increasing this diagnosis that will be important. Treatment option that we have now, surgery, radiotherapy, chemotherapy, palliation, provide access to opioids, as well as accompanied by research, where we'll be using research to see the evidence of what we are doing, what we're implementing, if they are really working, and where we need to improve. So talking about the issue of cancer in general, as well as the source constraint that we have, most of the time in the LMIC countries, as well also, I know it is also happening the same globally. We have minimum resources, and we must identify where to put this, where really we might put our little resources, using them effectively. Then Pro Pharma and colleagues, they categorized some of these where we're supposed to put more effort regarding what we are able to do. They started by questioning themselves, where do we get most bang for our buck in global cancer? That's where they came up with these categories, where they highlighted that we should see or invest in cancer treatment, depending on these the following categories: preventable cancers by risk factors, including cancer, papillomavirus, as we mentioned these are the preventable cancers. We also have cancers that are potentially curable with early detection, including cervical cancer, breast cancer, colorectal cancer. Also, we have cancer that potentially curable with systemic treatment, as they highlighted, including Hodgkin lymphoma and others. And the last one that they highlighted, cancer that are often well palliated with systemic treatment, including carcinosarcoma and advanced breast cancer. Then, being that side, at a global level, we'll talk about Rwanda in the context of cancer care in Rwanda. A little bit about Rwanda for people who haven't been here. Rwanda is located in East Africa, and it is one of, like, if I can say, best country now. But I can't forget that we had a tragic genocide against the Tutsi in 1994, where everything that was deteriorated, including health system, of course. So, but regarding that issue, that tragic genocide against the Tutsi that took place, Rwanda has advanced and worked well to improve the health system as well as other sectors. So I can talk of cancer care in Rwanda, leaving behind where it started. It started in a collaboration with Partner Health, where government in Rwanda collaborated with Partner Health, and they built which I can call its first cancer treatment center in Rwanda, in a rural area where I'm now seated right now, in 2080, and then the treatment center started working in 2012. You can see here we have Paul Farmer, our co-founder, as well as Billy Keaton and the other local leaders in the country. That's when the hospital started being built, and this was at the end of it. And we did the entry of this. So cancer care service has expanded nationally, not only in local areas that I've mentioned, from Mutaro to be expanded into other areas in Kigali and in the other southern provinces. where we have at least different treatment center and as well as hospitals. Rwanda Military Teaching Hospital serves as now National Cancer Center and hosts Rwanda's first radiotherapy services, treating up to 150 patients per day. We also have King Faisal as one private sector that is offering specialized cancer care in Rwanda. We have also other teaching hospitals, including King Faisal, Siashibe, also delivering cancer care services to the community. National Cancer Control Plan, which took place between 2020 2024, they launched a framework for cancer prevention, treatment, palliative care, and integrating cancer services into national health system. So recently they set up the mission of the launch RBC and Rwanda Biomedical Center, Ministry of Health. They launched the goal of eliminating cervical cancer by 2027 through vaccination, screening, and treatment. So financing strategies, we know that also doing this, it requires a lot of money. That's where the government of Rwanda, as well as its partnership, they came together to see how they can mitigate this issue. So since the establishment of Motaro Cancer Center of Excellence, PIH has been supporting in the provision of free cancer care services for cancer patients. Until July 2025, the government of Rwanda introduced financing for cancer care coverage through community-based health insurances, also called Mitwell. This is a public health insurance where I can call it a solidarity principle, where the families they contribute, and each family after contributing they are able now to use that CBHI as public health insurance. When they go to the hospital, they have to pay only 10% of the expenses that they have used for their care services. But despite that, we still have some challenges. Mostly financial toxicity continues to affect patients. So be it in transport, food, as well as lodging, because most of our clinics, as we have seen, they are located in two cities. So our patients, they have to travel far from their homes, which they'll be required to have some amount to pay in terms of taxi, in terms of transport, lodging, as well as food, as well as their caregivers who will be accompanying them. So currently, insurance coverage is limited also. Is limited primarily to curative medication, and we have also seen that we need supportive as well as palliative care medications. That's also another challenge. Now talking about Butaro, where I'm now seated, we have like around 257 bed capacity. We have, among our patients, 51% of them are cancer patients. Outpatient visit, we have over 28,000 per year. Average bed occupation rate, is higher, which is rated to 100%, 120%. Number of deliveries per year, more than 2,200 deliveries that are happening per year in Butaro. So the basic oncology services that we are providing includes biopsy, pathological diagnosis, radiotherapy, general surgeries. I'm talking about mastectomy, colorectomy. Also, we have specialties. We refer them to Kigali, and that means that we refer them to Rwanda, be it in Rwanda Military Hospital, King Faisal, or Seashika. We also provide chemotherapy, referrals for radiotherapy, as we have seen that we only have radiotherapy from Kanombe, which is Rwanda Military Hospital. We also provide supportive care, access to IV or morphines, counseling by dedicated clinical psychologists, as well as social economic support. So these are common cancers that we treat here, including breast cancer, cervical cancer, head, neck, gastric cancer, colorectal, lymphoma, CML, liposarcoma, LL, and so on. This shows that one of our clinician is the director of oncology program here in Department of Health, treating and assessing a pediatric patient in Butaro. So patient-centered communication. Now I'm going to talk about our program, our research program that we are having now. This is the Butaro site, which has been expanded lately in support of PIH and the government of Rwanda. Talking about patient-clinician communication in cancer care. Cancer care requires complex communication skills, discussion of diagnosis and prognosis, responding to emotion. We know that cancer care, we know how patients are what they are going through, which could impact their emotions, and then we have to respond to that. The clinician have to respond to that. Goals of care, including curative intent, palliative intent, as well as shared decision making. High quality communication. We believe that the results include good outcomes. So talking about communication, clinician communication between patient, and we also have to talk about cross-cultural variation in the communication practices and preferences. Here I would highlight that we know that in the global north, they prefer a patient autonomy, which is a bit different from most of our LMIC countries, including Rwanda, where families as well as doctors, they make decisions rather than patient autonomy. That's the cultural variation. So how, like within our program, how were we able to come up with the idea of the intervention that we did? We used the human-centered design. This is the design that is being used with the business people. We thought of how use their framework, inspiration, ideation, as well as iteration. Inspiration is about framing a design challenge, discovering a new perspective on the opportunity. Ideation is about generating ideas and making them tangible. Iteration, it's about continual experimentation based on user feedback. And then we came up with designing a challenge with this question: how might we improve communication between the patient and clinician in Rwanda? Then within the context of inspiration, here are the patient voices that led us to provide our intervention. One patient highlighted that, "I'm often told that cancer does not have a cure. They don't explain these things clearly, so we are not well informed." Second patient highlighted also stated that, "If a provider sees that my cancer is not curable, instead of dying far away from my family struggling, asking, he died in Ruhengeri, that's one of our hospital around here. So how are we going to get the body for burial? It can be better to tell me, listen, we are unable to cure you. Now you take this medication to alleviate your suffering. Go and stay home to avoid dying away from your home." That shows really how family perspective that it is, how culturally in Rwanda we do consider family perspective. Then we also did focus group discussions with clinicians. So these are some of the findings they highlighted. First one was about the breaking bad news. One of doctors, he highlighted that it is always difficult for me to deliver a bad news, to the point that I don't break such a news to every patient I receive in order to avoid keeping their image in my mind. That was the point where he showed the issue with breaking bad news. Another nurse, oncology nurse, she responded, "No sooner did I tell her about her illness than she broke into crying. I had difficulty calming her down. You can imagine how it feels when you are with someone and she cries. Also, that's what she stated. About the persisting desire of providing communication skills training, they highlighted you can give us skills based on international standard, but then we adapt those skills to our culture. Definitely, we should learn the standards that are followed elsewhere. This is important for us. And then, while designing this, we also have this community. We already identified the issue, the gap, and the need of communication training. So this was our second design challenge, where we asked ourselves how might we develop communication skills training for oncology clinicians in Rwanda that optimally fits the local context, the cultural context. So we used some of the tools from this big program, VitaTalk, which has like various tools that could be used for communication training, skills training. Then we use some of their tools. Approaches that we used, as I mentioned, it's from human-centered design, inspiration, ideation, and implementation. We used focus group discussions. As we highlighted, we saw some of the feedback from qualitative results. And for ideation, use focus group data to adapt the training materials. We had them, and as well as so we had the trainees, clinicians, also providing their insight on how better way of it is articulated, not getting it the way it is and then it being implemented. Rather, we had them to provide their input depending on how things are being implemented, services are being implemented in Uganda. During implementation, we did iteration one, where we did a training with the clinical psychologists. It was the first one in 2023. Facilitators, we had also feedback from them. We did a facilitator evaluation as well as brief. And pilot 2, oncology, we did also training with oncology and palliative care providers. We did also the brief focus group discussion to see how the training went, as well as how we could really adapt these training materials into Rwandan context. So the training objective, we provided the training around delivering bad news, as we saw that it was one of the important points that were highlighted with one of our participants, saying that they were not able to respond to how they can provide, breaking bad news. Another objective was responding to emotion. We used nurse for responding to emotion and the guide for delivering bad news, which both of them, we bought them from Vitotech. Talking about the implementation, this is the agenda that we used, which we hope it can be also implemented. It is doable. It can be implemented with similar settings, countries that you can use. These are the guides and as well as nurses tools that we use on our trainings. Communication skills training for oncology and palliative care providers in Rwanda. Training activities included interactive lecture, demonstration, practice in pairs, small group discussion, large group debriefs, debrief focus group, as well as data collection opportunities. These are our previous training last year that we did. So I'm bringing also this framework which we developed, and we thought that it might be helpful for the future implementer of these kind of trainings, where we thought of, instead of getting the tools and you go through all different researches steps that we know, it's overwhelming, but we thought that these tools, they can be adapted as well as conducting the training. This structure shows that this is the traditional training that is being that's how it is being provided. lecturing, demonstration, practice in pairs, small group discussions, self-reflections. But we had another component of how are we adapting these tools into Rwandan context. Aside, we had also these lecturers, those lecturers, we included interactive lectures where the participant could share their beliefs on how they think that different phrases, different skills that are into those training tools, they could be fitting, they could be rephrased, or what they could propose instead of having, like, let's say, get ready in the way it is written from the original tool. They would propose other options depending on how the services are being implemented, how the communication is being done. Also, that would be done into large group debrief, where from the small group, then we came into large group and shared the feedback with others, as well as they also provide their input regarding on how they can contextualize those tools into Rwandan contexts, as well as large group. So as the editation comes in as well, that's how it is being done. So prototype for integrated training, we thought it's, as I mentioned, it's a pragmatic. It can be done elsewhere, not only in Rwanda, with less cost effectiveness. We had pre-work, recruitment facilitators, that's normal, selecting trainees tools, translate the tools, because most of them, they are coming from US-based companies. Develop script for practices, make plan. These are pre-work that we had to do, and then also including post-work. Rapid analysis from these debrief focus group discussions. We had some data that we had to do rapid analysis. We used to do rapid analysis, modify tool depending on the feedback. So we tried this one as a meaning about communication skills training. We tried to bring in our recent communication skills training that we provided Friday. We used this framework. We hope that it worked, and we look forward to do the analysis of the data that we got from our previous training. Now we provided the training. We have seen where to improve. Then how are we going to measure our communication in Rwanda, or training that we are providing in Rwanda? So how can we evaluate communication quality in Rwanda? We can do it in different ways: observation method, including audio, video recording, clinician self-report, survey. But on our side, we preferred patient self-report survey as an opportunity for empowering our patient. Then this is also the slide that shows we are getting these different surveys from Global North, and then they are implemented here. We use them into our LMIC, or Global South, if I can say. But in between, there is a way how we can adapt them so that they can respond into the cultural context that our people should be responding to. We know where these things is coming from. We've been colonized by this global north, if I can say. And also there is this debate around this. Should we use the tools as the way they were developed from global north, or should we develop our own as people from global south? How should we develop them? And then our context, as I mentioned, we preferred a cultural adaptation in the middle ground, where at least we could use those developed from a global north, but we do the adaptation, including the perspective of what is happening. So speaking of that, we had a patient-centered communication cancer, which has a survey, which has 16 items, and then we wanted to do our method, which is a culture adaptation process. We used the verify process to modify the survey, as well as we're hoping to do as our next step, psychometric evaluation to validate the survey in Rwandan context. This is the tool that we used, also from the US, as I mentioned. So the process, the verify process, we included the group of expert oncology clinicians, including oncologists, general practitioners, oncology nurses, psychologists, social workers, so that they could come and we discuss about these items, whether they are responding to our community needs or to our patient, as well as they could also provide new ideas on how they feel that the survey could be developed instead of like implementing it the way it is. So these are our feedback. The feedback now we have. I've mentioned that we started with 36 items, but from the verify process, only 19 of 36 items reached consensus in the final round, which is we did 3 rounds, round 1, round 2, and 3. Then only these 19s they reached round 3 as they reached our consensus, which was to be above 70%. We included also 3 newly suggested items. That means that from the original 36, they proposed adding other new items within this 19. Most modifications were made focused on Kinyarwanda translation as well as phrases. The way it is translated, it was dialect, and then they wanted to put it in Rwandan context. Survey length also, we had the expert recommended to shorten the survey. Survey item framing, preferred term majority choose the term doctors and other health professionals. That means that from our questions, we use doctors and other health professionals. But in the Rwandan context, some of the clinicians, they highlighted that most of our patients, they call everyone within the hospital a doctor, not differentiating nurses, a psychologist, a social worker. So they prefer using a doctor in general. But with the contribution as well as the feedback from the clinician at the final stage, which is within round 3, they recommended keeping doctors and other health professionals as it is showing the multidisciplinary teams within the hospital. Question focused on most participants are supported keeping questions addressed to patient only rather than including family. So during our process, verify process, some of the clinicians they recommended developing questions that includes family as well as patient, because not keeping that patient autonomy, but also in a one perspective in our culture, accepting that the family plays important role within the patient. However, at the end, it was found that we should keep it or address it to the patient rather than keep it in general of including family members. So our ultimate goal now in general, as I'm winding up, is to improve the quality of patient-centered care for patients with advanced cancer care in the context of Rwanda, to develop, implement, and evaluate context-appropriate intervention and culture measures, quality measures. This is what we have been doing, and from formative evaluation, patient and clinician perspective, intervention development of communication skills training, as well as doing adaptation, which we have been doing now, and we are hoping to do in the near future a clinical trial of clinician training intervention using adapted measures for evaluating these kind of intervention. These are the grants that we have been using. As I'm ending, I also like to acknowledge like my institution, Paternity Health, UCSF, Dr. Becky in particular, Global Cancer Program, IGHS, for this important program, as well as my mentee, Dr. Vincent Chubaka, our Director of Oncology, Sprian, as well as other partners, including Government of Rwanda, Botaro Center, Cancer Center of Excellence, as well as Global Health Equity. Thank you so much.
Great. Awesome. Thank you so much, Musafiri. That was wonderful. And thank you all for joining. It's great to see a lot of familiar names and new friends. Um, so the plan for the remaining time is to have a discussion um, and then a Q&A. And I think we have a little less than 20 minutes. So maybe what I'll do is get started with some discussion questions in the next 10 minutes and then open it up to the audience. Um, and then I guess Musafiri, if you want to, you can take down the screen share, I think,
Mhm.
and we can kind of, yeah, um, have our faces be bigger. Okay, so again, my name is Becky DeBoer. I'm a medical oncologist and faculty at UCSF. My clinical practice is at San Francisco General Hospital, and I've had the privilege of working with Partners in Health at Butaro Hospital for about 11 years, and collaborating with Musafiri and Vincent and others on this communication research. Um, I think what I'll do, Musafiri, is start with some questions that are more about the research, and then sort of step back and ask some broader questions about global health partnership, since that is the theme of this series. Um, so, you know, when in hearing you go through um, the research projects and the questions, sort of the broader question about adaptation, I'm really interested in your reflections. So you described our project to adapt communication skills training and to adapt this survey. And I know you've taken a deep dive into the specific adaptations that have been suggested and made. And when we think about that spectrum that you showed, um, between just, using tools and surveys that are kind of, exported from the global north on one end of the spectrum, and sort of developing de novo tools and interventions um, in each country on the other end. What do you think about sort of the best approach um, to doing these adaptations? Um, where on the spectrum should we be aiming, and how do you think about that?
Mhm. Yeah, thanks so much. That's a great question. I believe like for now, we should be where we are now in the mid we envisioning high. We should be envisioning high on how we start developing our own tool. But in the meantime, it requires like different resources, much resources. But in the meantime, we should be also starting adapting those tools, but at least doing what we are doing now, like inviting our expertise into that field, and then inviting their ideas on how really these tools they can be contextualized into their culture instead of starting from scratch, which takes some time. Those tools that were developed from global north, they are really good, so we can't leave them behind. But in regarding of financial resources, regarding of the time that many of the time we don't have while envisioning to conduct different researches around that, we should be standing on the side of adapting the tools regarding the cultural context that we are using.
Mhm.
Thank you.
Thank you. And I guess the follow-up question from the communication skills training adaptations, you mentioned a couple of examples of, cultural variation in communication between doctors and patients. Um, were there any sort of adaptations that, or maybe lack of adaptation and lack of differences that struck you in your analysis of the training interventions? Like, are there any cultural differences between the Vital Talk tools and the Rwandan adaptations that struck you or that made an impression on you?
Yeah, thanks so much. I think for sure it is very high at late because as I mentioned that those tools they have been developed from Global North, and they are more of patient autonomy, not including the values of that we give values to our family members, our caregivers. But while discussing, while providing the training with clinicians, as well as hearing what they are saying, they are giving that family as an important part, as an important component to the patient, rather than considering only a patient, which we call patient autonomy. Also, the decision making. Decision making, most of these tools, it's as if patients they are making their own decisions. But in our perspectives, it is not, most of the time it is not happening that way. Clinicians, they tend to make decisions for the patients. As well, the patient, they tend to include their family members while the decision of their clinical services are being provided. That's some of the striking point that I saw as the differences from these tools as well as our cultural context. Thank you.
Thank you. Okay, thank you. Now, I think maybe I'll zoom out and ask a question or two about your experience um, with our, broader partnership. And I think you've highlighted really well um, the mission of Partners in Health and the role of Partners in Health in cancer care in Rwanda. Um, and I know that Partners in Health is the sort of primary goal is to accompany the Minister of Health in delivering care to patients. Um,
Mhm.
and yet research is also part of the mission,
Mhm. Sure.
although it may
Becky, you're
Breaking.
breaking up. It
not
looks like your Wi-Fi is
be
a
the
bit.
primary mission. So just didn't, oh no,
Yeah.
is it better now?
Yeah, now it's better.
Sorry about that. Okay, I'm so sorry about that. Well, my question has to do with what are some of the maybe challenges that come up with, trying to prioritize research in the setting of a care delivery organization, and some of the opportunities.
Mhm. Mhm. Yeah, thanks so much. That's a good question. I see it, if I can say, in three different angles. The first angle or the first point I could highlight is the preferences or the priorities that NGOs or partner in the house itself that is envisioning. One could be that these NGOs, they are focused, most of them, they are focused on service delivery, as I mentioned. Research comes in as a secondary or even a competing with a patient care priorities. That's first point. Also, resource constraints, limited funding, infrastructure, personnel make it difficult to sustain, if I can say, rigorous researches alongside care delivery. That's another part. Also, these NGOs, they may not have, or most of them, they don't have that robust electronic system records or research graded data systems that they can, which can complicate analysis as well as getting the data from that system. But to overcome the challenge, which I thought it's thinking in designing the research, programmatic research is all studies that align with a clinical workflow, if I can say. So the research strengthen rather than disrupting the care. That's one part. Also bringing in innovative financing approaches, seeking maybe branded funding models that support both service delivery as well as the research. That's how I can say that could be contribute in both ways, NGO, I mean, mission as well as research component part. Thank you.
Great, thank you. And maybe, well, let's see. What I'll do is open it up to the audience. I have a long list of questions I could keep asking, but I want to make sure we have time to get to audience questions. So if anybody has a question, feel free to raise your hand or put it in the chat. We'd love to hear from you. And so don't be shy.
Yeah, please feel free to unmute yourselves and ask your question and turn on your camera if you can. Hi, Payam.
Hi, Prabha. Hi, Rebecca. Dr. Musafiri, thank you very much. I'm Payam Naid. I'm the Executive Director for Institute for Global Health Sciences. I really enjoyed your presentation. Just wanted to ask you if you could expand a bit on the reliability of chemotherapeutic agents and access, and how that factors into patient perceptions of their prognosis and how that influences your communications with them.
You're saying, sorry.
Were you not able to hear me? Sorry. Can you guys hear me?
Yeah.
But I can hear you.
Could you comment a bit on access to chemotherapeutic drugs and whether that plays a role in the way you communicate with patients and how you handle the uncertainty, if there is uncertainty about access to drugs?
Yeah, thanks so much. That's a great question. Like access to chemotherapy in Rwanda, it has been for so long supported by partners, with the government of Rwanda, in collaboration with the government of Rwanda. Most part, like Partner Health, used to provide the chemotherapy. Then also it doesn't mean that it is providing it like in a sufficient way, because they're also using funds from donors, which could also be another challenge. But they have been trying for their best so they can provide those chemotherapy to the patient. And regarding the point of patients not being able to get the chemotherapies as they are supposed to be, it might be also a challenge to the patient. But as a clinician, as the government of Rwanda, as well as its partners, including Partner Health, that's what they are trying to see, trying to identify where they can get the resources. And that's where they mitigate in the ways of finding the funds of how they can get the chemotherapies from abroad to Rwanda. At least they can provide the basic of those medications that patient they could get. Then we're still lacking behind on palliative care medications, which are much expensive, but other curative medications, government of Rwanda, as well as its partners, in collaboration with its partners, they are trying to get them for the patients. Thank you.
Yeah, and I can add sort of a clinical perspective as well. Thank you, Payam, for being here, and thank you for the question. I mean, I would say that it's the within the scope of practice, the scope of diseases that Partners in Health is able to treat, the supply is pretty consistent, although there are stockouts. But as Musafiri highlighted, there are several diseases that we are not able to treat, or after first line, we don't have access to second line therapy. And for sure, that contributes to the difficulty, I think, of these conversations. And some of those quotes from doctors saying how challenging it is to break bad news, I think really reflects that limited access to treatment. And I think the other way that resource limitations really affect communication is when it comes to shared decision making. And as Musafiri highlighted, the patient, even with the heavy subsidy from Partners in Health and the government, patients still have to pay something. And in order to do that, many of them sell their assets or, collect money from family and community. And if they're not aware that the treatment is not curative, that, really affects those, I think, the quality of those difficult decisions. So that's sort of what has motivated our ongoing work and training and trying to empower clinicians and patients to have these conversations.
Excellent. Thank you both.
Other questions?
Yes, hi, Laura, go ahead.
Yeah, thank you both so much. Musafiri, great to, hear you start with the global and Rwanda context and hear more details on the work. And thinking more about the patients, I saw, in your Delphi, you have the patient advocates that you consult. Are there plans in your next phases to have more interviews or consultations with the patients on their perceptions of the communication? Just wanted to hear more about that.
Yeah, thank you so much, Laura, and it's good to see you again. Yeah, it's been a while. Then, yes, I could say that even now we are doing cognitive interviews with the patients. So we want to hear more from their experience, though most of it's about how they get the items that we have now. But we also give the chance to hear their feedback around the communications. Also, after that, we also go to if I can say, the big number of patients using this tool that we are developing, asking them their experiences about communication between their clinician and the patients. That's why we get a big feedback and hope to have more big insight on the level of the patient. Thank you.
So I actually have one quick question. I know we're almost at time. I was wondering, do caregivers, is there any plan to also include communication with caregivers or communication between caregivers and patients? Because caregivers are such a big part of, the patient's journey as well, particularly, when dealing with cancer. Just curious if there are any thoughts of including caregivers.
Yeah, thanks so much. Because as I mentioned from the beginning, it's the caregivers plays a big role in our culture. Then in the near future, we start thinking how we can also include them into this cycle of patient-clinician communication, because they are playing a big role into taking care of our patient when they get home. And one patient, they told me that when we left here from the hospital, what people that are taking care of us, they are our family members. Then bring them here, and then you discuss the prognosis. You discuss like how far is my disease. That gives them hope. That gives them the way how they could keep providing the support they're supposed to provide at home. Then we are hoping to include them too. Thank you.
Thank you very much. Well, we're over time here, so thank you very much, Musafiri and Rebecca, for this excellent presentation and discussion section. Thank you very much, and thank you to everyone who also made the time to join.
Thank you so much.
All right.
Thank you for having us. And yes, thanks
Thank you.
everyone for joining.
Thank you.
Okay,
Thank you so
bye-bye.
much. Bye.
Thank you all.
Bye.
Thank you.